your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Good evening. Welcome to Dr. Gore's show. Today we're going to talk about minimally invasive gynecological surgery. What does the word minimally invasive mean? When there is less invasion, less cutting, that's what minimally invasive surgery means. Open surgery is where a big enough incision is made for the surgeon to put the hands inside, to do the surgery, to feel the organs, retractors, etc. The disadvantages of open surgery is there's a larger incision, there's more pain, you need to be hospitalized, there's more blood loss, a lot of days out of work. In the future, there's a more risk of scarring, more surgeries. When we do minimally invasive, what does that mean? That means that either we don't cut or we cut through small incisions, usually anywhere from 3 to 10 millimeters, and we do surgery through telescopic instruments to do the surgery. Since there are small holes, there's less pain, there's less bleeding, patients are sent home the same day, and they tend to return to work easier. There's definitely less blood loss. So what are the different routes of minimally invasive surgery? The routes can be vaginal, laparoscopic, and robotically assisted hysterectomies, surgeries, which is called Da Vinci system. So in vaginal surgeries, they can be either simple vaginal or hysteroscopic surgeries. Vaginal surgeries are usually done when there is a prolapse, there is a pelvic relaxation, there is a prolapse of the bladder or the rectum. Those surgeries are vaginal hysterectomy, vaginal TVTs, anterior repair, posterior repair, enteroceal repair, things like that, that we train and we did it. But there are limitations. Not all patients can be done vaginally. You need to have a small uterus, some relaxation to do the surgeries. Most of our patients who are undergoing hysterectomies, they either have fibroids, endometriosis, tumors, or a bleeding disorders or called dysfunctional uterine bleeding, and they don't have much relaxations. So vaginal hysterectomy is limited for very limited number of patients. Hysteroscopic surgeries are similar to vaginal, where there is no cut, it is done vaginal approach, and we take out small fibroids, small polyps, and any growth which is inside the lining, and do surgery without any incision, without any cut. Patients goes home the same day. Usually they are fine to do that work next day. Then we come to laparoscopic surgeries. As you can see on the slide, there is an open surgery on the left side, and then there is a laparoscopic surgery and vaginal surgeries, which is shown. Laparoscopic surgeries are done through small keyhole incision, where we pass the telescope and we do the surgery. What are the drawbacks of this laparoscopic surgery? So laparoscopic surgery was in practice in 90s, and it really changed the way we did surgeries. As you can see in the next slide, definitely there is less blood loss with laparoscopic compared to open. Patients returns to work, less pain, less scarring, improved in cosmesis. But then there are drawbacks. The drawbacks are, if patient is obese, if patient has large uterus, if patient has endometriosis, if patients have adhesions, scarring, we can't do this surgery through laparoscopy, because these instruments are rigid instruments. They are not mobile. They don't tend to move. The movements are done at the far end while the tips are on the other end. They are not very dexterous. There's no magnification. you are dependent on your assistant to hold and show you the area. There's definitely more surgeons fatigue. So those are the drawbacks of laparoscopic surgery. But the advantages are there. So there are certain cases can be still done laparoscopically while the uterus is not too big, there's not too big fibroids, or there's some small cyst in the ovaries or tumor in the fallopian tube, or there's any mass or any cyst. That can be done through laparoscopic approach. Now the instrumentations have improved, and most of our approach, especially for hysterectomy, myomectomy, endometriosis, and pelvic relaxation, which requires sacral surgeries, and few limited gynecologic cancer, uterine and cervical, can be done through robotic route. Let me tell you, most of the cases done in this country are hysterectomy. It's the #1 benign surgery done for women. It can be because of fibroids, it can be because of dysfunctional bleeding, endometriosis, or prolapse. As you can see in the next slide, you can see the configuration of fibroids. The fibroids can be outside, inside the muscle of the uterus, or in the lining of the uterus. So these are called exophytic fibroids, intramural fibroids, and submucosal fibroids. Depending upon the presentation where the fibroids are located, people are going to have different symptoms. If it's in the lining, one is going to have heavy periods, miscarriages, intermenstrual bleeding, cramping, and pain. While the fibroids which are in the muscle is going to also give you heavy periods and cramp and pain. Fibroids which are outside, exophytic fibroids or subserosal fibroids, when they grow, they give pressure depending upon where it is. If it's anteriorly, it's going to give pressure on the bladder. If it's onto the bowels, it's going to give pressure symptoms. So depending upon the location, the surgeries are done. As you can see in the next slide, number 8, where there is a different approach of taking care of fibroids. If it's in the lining of the uterus, you'll take care of through the hysteroscopic part. If it's in the outside or exophytic, then you do either laparoscopically or robotically. So what's a robotic surgery? What's a Da Vinci system? Most patients ask, are you doing the surgery or robot is doing the surgery? Are you in the room or is the robot doing everything? It's going to go crazy. What's going to happen? It's all valid question. So as you can see in the next slide, there are 3 components of robotic surgery. A, there is a console where the surgeon sits down. Then there is a patient cart where all the instruments are loaded. And then there is a vision cart where all the instrumentation is kept. On the console, as you can see in the next slide, the surgeon is sitting at the console and does small movements. And those small movements are getting transmitted onto the patient side where all these instruments are attached. So how does this work? So once the patient is brought in the room, like any other surgery, anesthesia is given, different positions are given, patient's abdomen is cleaned with antiseptic solution. We put the small holes depending upon where the pathology is, put in small telescopes, bring in this robot and attach it. Then I scrub out, sit on the surgeon's console, look under that vision thing. As you can see in the next slide, as I'm looking inside, it's going to move my hands and it's going to keep doing surgery, and that surgery gets transmitted onto the patient. How do we do this? So when we are looking inside, every small movement gets transmitted to do surgery. Advantages, A, because there's a 10 times magnification, there's less bleeding, there's less scarring. The patient tends to do much better. There's less pain, less bleeding. Patients are fine and they go home most of the time the next day. As you can see in the next slide, it shows that the robotic instruments have a movement which is called dexterity. They move all different directions. That's why you can do a difficult area. You can go back, you can go front, you can go sideways. As you can see in the next slide, all these movements which are exaggerated are fine. That means that even if your hands are moving or your hands are shaking, that shakiness at the end is gone. So it's a very, very precise movements. Why robotic surgery? Because we can do such a difficult surgery through a small incision. Hence, there's no need to cut somebody with a big incision. The amount of bleeding is very minimum. As you can see in the next slide, compared to traditional laparotomy to traditional laparoscopy, the patient's cut is very small, the bleeding is less, they are up and around the next day. Robotic surgery compared to laparoscopic surgery is not limited by patient's weight, the size of the fibroids or size of the tumor, and even in a difficult situation where there has been previous surgeries, scarring, where we don't have a deep access in the pelvis under the bony part, here we can still go through with the help of robotic instruments behind the scarring to the lateral wall, to the side wall, and do the surgery. Hence, the patient's recovery is much better. We're going to take a short break and we'll be right back.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.
Welcome back. Today we are talking about minimally invasive gynecological surgery. That means that doing major surgery through small keyhole incisions. How is that possible? By having a great tool with us, which is the Da Vinci system we have. We've talked about what the system consists of, what we do, what different surgeries we do, and how it's better. So now let's talk about individual procedures. The most common procedure done is for fibroids, as we discussed, which are the benign tumor of the uterus. This can be different locations. In a young patient who desires to keep the fertility, that means that the patient wants to have children, we take out the fibroids. This fibroid, when they are intramural and exophytic, that means in the lining, in the muscle of the uterus and outside the exophytic part, these are the fibroids which are removed through either laparoscopic or robotic Da Vinci system. Why Da Vinci is better than laparoscopy, especially in cases of myomectomy? Because these fibroids are very vascular tumors. They are big. They can be as big as 1 kg to 2 kg. My biggest fibroid that I've taken out is 2 kg. It's almost like 4.5 pound, 5 pound size fibroid, which is like 7 to 8 month size pregnant uterus. So it's just in comparison how big that uterus is. Now, when we do it through Da Vinci system, the blood loss is very minimum. On an average, somebody can lose anywhere from 500 to 1000 ml of blood during such surgeries. When we do it through Da Vinci system, the blood loss is 50 to 100 cc. So you can see how much of benefit of less blood loss is. Number two, when we cut the fibroid, we take out the fibroid. In case of laparoscopy, it's very difficult to close that uterus back with the help of sutures. With robotically, because the instrumentation is easier, you can move the wrist just like our wrist. It's called endo wrist on the instrument. It's easier to tie the knot. So you have a very strong scar on the uterus to prevent any difficult labor in the future. You can get pregnant, the uterus can grow without any complication of rupture. For those two major reasons, Da Vinci is a much better choice for myomectomy. Going to endometriosis, which is another condition where there's a lot of scarring, there's a growth of endometrial lining which is supposed to be inside the uterus, which happens outside. Most of these patients have severe pelvic pain, they have difficulty getting pregnant, they have chronic pain, or they have severe pain during menstruation or intercourse. These are the patients where Da Vinci's system helps, because we can see the scarring very well. We can attack only the scarring, making sure not to damage the ureter which carries the urine from kidneys to the bladder, avoiding any major blood vessel trauma, less scarring because you're not touching any other tissue. So in the future, the recurrence of scarring and pain is much less, and we have a better pregnancy outcomes. Hence, for endometriosis, definitely Da Vinci is a better system than laparoscopic surgeries. Coming to hysterectomies, why Da Vinci is better than common laparoscopy surgery? As we mentioned, most of the time we do surgery for dysfunctional bleeding, fibroids, or any tumor. Those are the common causes where we do hysterectomy for benign causes. There can be early cervical cancer or early endometriotic cancer of the lining of the uterus. We have to do hysterectomy. There too, robotic surgery is a better tool. Why is that? Because you don't have to give them a big vertical scar or a bikini scar, and you make 3 or 4 5 to 10 millimeter small holes on the belly, do the whole surgery without opening them. They go home the same day and they are fine to carry out their daily functions in few days. So such a difference from staying in the hospital for 3 days, taking 6 weeks to recover. Now somebody's fine to go home the same day, they are walking around the next day, and they can go back to work in 3 weeks. The amount of time saved, work time saved, is much, much better than the cost which you hear about in the newspaper. Like any other surgery, it's not without its risk. Any surgery is always associated with infection, bleeding, damage to any organs, if not performed well. But hence, that's where you do your homework to make sure why you're doing a surgery. Have you tried every other non-surgical options before? Why some patients will benefit from myomectomy, why some patients will benefit from hysterectomy. Those are the things we need to go through and figure out. Going to other causes of surgery is called pelvic relaxation. Usually we see this in elderly patients where there is a relaxation of the bladder and the uterus and the rectum. Usually patients complain of something is falling out, a lot of pressure, pain, difficulty in urination, etc. These are the patients where, along with the hysterectomy, along with taking out the prolapsed uterus, we need to do what's called support surgeries. Support surgeries can be anywhere from supporting the bladder, supporting the vagina vault and attaching it to sacrum, or doing an enteroceal repair where we push all the bowels up and put a mesh. That way the organs don't prolapse again. All these are very delicate operations associated with bleeding and infection. Here we used to do a big belly incision. Now we are doing it through 3 or 4 holes. This support helps women not to develop prolapse in the future. As far as going to early gynecological cancer, if somebody has cervical cancer, which we pick up on pap smear, biopsies, colposcopy, and if they are staged correctly, in early stages, they need hysterectomy and lymph node dissection. These are a very difficult procedure where you have to go onto the side of the belly, which is underneath a layer of fat. It's a very difficult surgery, and hence most patients used to get up and down incision before Da Vinci system came into play. Since we have small holes and our instrument can go 90 degrees, 180 degrees, we can take out the lymph nodes from the side wall without opening up and making a big incision. Same thing for endometrial cancer. When it's a cancer of the lining of the uterus, if found earlier on, they are a good candidate for taking out the uterus, the tubes, the ovaries, and the lymph nodes from the pelvic side wall. These difficult surgeries can be performed with minimal blood loss through Da Vinci system. Like any other surgery, we always have to counsel a patient, give them the advantages, disadvantages, benefits, risk of the type of surgery they are undergoing, the type of instrumentation we are doing, the type of approach we are doing. There's no simple answer. While there's no one size fit all in medicine, we have to individualize the patient, find out what's the problem, what is causing you the issues, and hence tailor make the plan. Your friend might have had similar issue and the surgery performed on them might be different depending upon the size, the location of the tumor. If they are older, they are younger. If they are wanting baby, they are not wanting babies. So always ask these questions. The most important question one has to ask is how many surgeries your surgeon has done. Are they experienced? What's their track record at the hospital? If there is any complication rates, if they've had any issues, you have to do your homework before undergoing any surgeries. So I hope there's some enlightenment on the topic of minimally invasive gynecological surgeries. This is a very important part of gynecological field for benign issues, and in today's day and age there are very, very few patients who need open surgeries. Even up to 1990s, 60% of the patients requiring gynecological surgery were open and only 30% were through minimally invasive route. In 2010 and beyond, only 30% are open and 60% are done through minimally invasive route. So in last 15 to 20 years, the whole numbers have changed. So there is no need, in my view, to do open surgery if they can be done through minimally invasive, because the advantage, as we've discussed, are much more than doing an open procedure. So please do your homework. If you need a surgery, please get a second opinion. And if you like to come and see me, my website is www.goremd.com. Office number is 201-541-6868. Thank you. Goodbye.
When your family's in need of medical care, where should you turn? Come to Englewood Hospital, home of the most advanced technologies and medical equipment. Home to Magnet Award-winning nurses who deliver compassionate professional care. And home to more top-rated doctors than any other hospital in North Jersey. For your family's health, come to Englewood Hospital. We're closer than you think.